Hi, welcome everybody. My name is Siobhan. I'm going to be your moderator today. My connection to the pheopara world is as a patient. 5 years ago, I was home alone with my daughter, who was 7 at the time, and I suffered a heart attack. It was an incredibly scary time for both of us. I was brought into the emergency room where they really had no idea what was going on. I was sent home and told to follow up. A few nights later, I awoke in the middle of the night where I was woken with the most crushing chest pain, severe thunderclap headache. I was throwing up, I was sweating. I was rushed to the emergency room where they had no idea what was happening. They brought in a neurology team who had done some imaging, and that's when I was told that I had suffered from 7 ischemic strokes. At this point, I was sent home and told this is reversible cerebrovascular constriction syndrome, and that I would be better in a few weeks. Everything would be fine. The problem was I was not fine. I continued to get very sick. And it wasn't until an admission a few months later that I had really pleaded with my neurologist to say, please help me find out what's wrong. At this point, he was able to order an MRI of my thoracic spine, and I was sent home. The next day, I received a call from the resident that they had found something. I had a nearly 5-centimeter tumor on my adrenal gland. I was able, thank goodness, to get in with an endocrinologist who did some blood work and a urine test, and it came back extremely elevated. And we finally had an answer. Everything fell into place. I had a pheochromocytoma. I am extremely lucky that I survived, and I am thankful to be here today. I am also thankful for the pheopara Alliance for their continued education, such as the webinar that we are attending today. I'm so sorry for our little bit of technical difficulty in the meeting beginning earlier. So thank you to everyone for being here. I will be presenting with Dr. Hans Ghayee, who I will introduce in just a few minutes. This program is brought to you by the pheopara Alliance, whose mission is to empower patients with pheochromocytoma or paraganglioma, their families, medical professionals, through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. A special thanks to Lantheus Progenics for making this webinar series possible through an educational grant. Some upcoming events we have. Next Thursday, October 12th, the pheopara Alliance is presenting a special informational webinar titled After Izedra, Moving Forward Together. This is with Doctors Camilo Jimenez, Daniel Parima, and Eric Mitra, who will be on hand to answer your questions about the planned spring 2024 discontinuation of Izedra. You can register and submit your questions on our website, www.pheopara.org. We will be in Gainesville, Florida on Saturday, September 28th, where Dr. Ghayee and other experts will speak at our last in-person regional conference of the year. Our next monthly support meeting will be on November 7th at 7:30 Eastern, 4:30 Pacific. November 10th is World Neuroendocrine Tumor Cancer Day. Please watch our social media for information on how you can help spread awareness about neuroendocrine cancers like pheo and para. On December 5th, we will hold our 4th annual Fireside Chat with the wonderful Dr. Carol Patzek, who will spend an hour answering your questions. On December 12th, we will present our last educational webinar of the year, The Multiple Faces of SDHB-Related Paraganglioma, at 9 a.m. Pacific, 12 p.m. Eastern. You can learn more about all of these events and register attend on our website, www.pheopara.org. Our agenda for today, Dr. Ghayee will present for about 30 minutes. Then we will have a question and answer session from the community. We will be asking questions submitted beforehand, but you're also welcome to type your questions into the chat section, and we will do our best to have all of these questions answered if the time allows. Keep in mind that many people will ask variations of the same question, so listen carefully if you hear a question that is similar. Questions that are less case-specific are appreciated. And of course, the disclaimer. The information presented on this webinar is for educational purposes only and should not substitute the advice of your doctors and medical team because they have an in-depth knowledge of your medical history and your current situation. It is now my honor to introduce Dr. Hans Ghayee. Dr. Ghayee is an endocrinologist and the VA section chief at the University of Florida College of Medicine and the Malcolm Randall VA Medical Center in Gainesville, Florida. Dr. Ghayee, welcome.
Thank you so much. It's really a pleasure to be here, and I'd like to really thank the pheochromocytoma Alliance team for giving me this opportunity to speak about this important topic of essentially no tumors yet symptoms. Let me share my slide deck with you. So again, I really want to thank the organizers for giving me this opportunity, and I do not have any financial disclosures relevant to this talk. However, I would like to disclose that what I'm presenting is a perspective that I have on this topic, and hopefully with that perspective, I have really simple objectives here, and that is we will consider the evaluation of persistent symptoms of pheochromocytoma, yet the individual does not have a tumor. And then we'll touch upon some treatment options related to this. So we'll begin with our first case, which is a 60-year-old man with a head and neck paraganglioma with an unknown pathogenic variant. He was operated on and this paraganglioma was removed, and his biochemical studies were negative. Yet, after his paraganglioma was removed, he had swings in his blood pressure. If we look at his imaging on the next slide, you'll see that initially he has this head and neck paraganglioma, and he was operated on by January of 2019, and subsequent imaging from that operation basically showed he had no evidence of any tumor, and all his biochemical labs are negative. So we're going to actually come back to this case in the next few slides, but I'd like to turn my attention on the next slide that talks about the symptoms and signs of pheochromocytoma. Classically, when we think of pheochromocytoma or paraganglioma, we think of a tumor that's causing nervousness, anxiety, flushing, palpitations, and headaches. And then less commonly, patients may have issues such as gastrointestinal problems. They may have nausea, vomiting. They may have some paleness that could be occurring. In the next slide, you will see that pheochromocytoma is a tumor that originates from the adrenal gland. However, there are pheochromocytomas that exist outside the adrenal gland, and we call them paragangliomas. Essentially, a paraganglioma can exist from the base of the skull all the way down to the pelvis. And these tumors essentially release hormones called catecholamines. And we are able to measure the breakdown product of these hormones called catecholamines. So when catecholamines are broken down, they're broken down into products called metanephrines or norepinephrines. And in the next slide, you will see that essentially when we are trying to make a diagnosis of pheochromocytoma or paraganglioma, at least biochemically, we are actually measuring these stable breakdown products of catecholamines called metanephrines and norepinephrines. And through the last several decades, we've learned that the sensitivity of both the blood test as well as a 24-hour urine test are very good, in the range of 95 to 98%. In the next slide, you will come across the issue of the fact that it is important that even if somebody has a positive biochemical finding, the question is this the real deal or not? And sometimes we come across the issue of interfering medications, such as tricyclic antidepressants, that can cause norepinephrine levels that can be at least 2 times the upper limit of normal, and therefore easily fool the healthcare team in thinking that the patient indeed has a pheochromocytoma or paraganglioma. And in such cases, what we would do is we would consult with psychiatry, taper the medication, and then see if we could retest the lab values. And obviously, other medications such as alpha blockers, for example, somebody's taking it for a prostate-related disease, and we see high levels of norepinephrine, and we find a way in which we can safely discontinue the medication and then basically retest the laboratory results either through the blood test or the 24-hour urine. On the next slide, you will appreciate the fact that whenever we come across a patient that has a pheochromocytoma or a paraganglioma, we check the blood test looking for that stable breakdown product of catecholamines called metanephrines, or we would do a 24-hour urine for metanephrines. And if the levels are about 2 times the upper limit of normal, then we would definitely consider the possibility of interfering drugs. And if that's not the case, then we would definitely repeat the test, because we never hang our hat on just one set of lab values. Obviously, if a patient has normal blood tests or urine studies, yet our clinical suspicion is really high based off of the patient's history, then we obviously would repeat the test just to make sure we are not missing something. And traditionally, whenever the tests are positive, that's when we jump to radiographic imaging, such as CT or MRI, to look for a tumor. And then if there's concern for disease that has spread, which we call metastases, that's when we would look at functional imaging studies, such as a PET scan, for example. In the next slide, what we'll appreciate is this, that when we come across a patient, such as this case that I'm presenting to you, who has persistent symptoms, and his biochemical studies are negative, imaging studies are negative, we're still thinking about the idea, well, could this patient still have a recurrence? And what's his genetic mutation? What's the pathogenic driver of his tumor? And traditionally, we think about certain genes that lead to very aggressive behavior. And in our patient's case, he didn't have any of these known genes that lead to aggressive behavior and possibly a faster recurrence. And I think an important concept for all of us to appreciate is that if the metanephrines are negative and there is no tumor on imaging, then symptoms are less likely related to a pheochromocytoma or paraganglioma. And the reason is this, that these tumors continuously release hormones where stable breakdown products can easily be measured with very high sensitivity. So we're basically at this conundrum with our patient, and that is, his imaging is negative, biochemistry is negative, yet this patient is having real symptoms. So what's going on here? And that's when we look at our differential diagnosis and the patient's history. And so some of the things that we start to think about, well, could the patient have kidney cancer? And because renal cell carcinoma is can be associated with certain types of pheochromocytomas depending on the pathogenic variant. So if somebody, for example, has a succinate dehydrogenase genetic mutation, some of these patients are at higher risk of developing kidney cancer, and therefore, we would ask ourselves the question, could the patient be at risk for this? And obviously, when somebody has such an entity, their blood pressures tend to be high, but they tend to be consistently high, unlike the erratic symptoms we see with classic pheochromocytoma. And not only that, when we are imaging our patients, we are actually looking for any other abnormalities that could be occurring, such as this. Another thing to think about, and which we did consider in our patient, is this entity called mastocytosis. So mastocytosis is a rare disorder where there's an accumulation of immune cells in the skin, bone marrow, or other internal organs. And these patients can have flushing episodes, skin lesions, they can even have diarrhea. And our patient didn't have any of the GI symptoms. However, his on exam, he also had nothing else that was concerning. But I do recall just recently seeing a patient in clinic who did actually have skin lesions very similar to what you see in the top right panel there. And through a further workup, she indeed was found to have mastocytosis and not a recurrent pheochromocytoma. And she's currently being treated by the hematology and an immunology group, and she's doing great. So the other thing that we also think about are carcinoid tumors, which are other types of neuroendocrine tumors that can cause flushing, fast heartbeat, difficulty breathing, and even diarrhea. And these tumors tend to be smaller tumors found in the gastrointestinal tract and sometimes difficult to diagnose. And whenever we are suspicious of such types of neuroendocrine tumors, we would do the biochemical studies looking for them, and also we would collaborate with our GI colleagues to determine if we can get an endoscopy done to look for them. Another type of endocrine disorder we do think about in the back of our minds is thyroid disease. So the thyroid gland is a small butterfly-shaped gland located at the base of the neck. And in many ways, it acts like the body's thermostat. So if we have an overactive thyroid, somebody can have a fast heartbeat, nervousness, tremor, and sweating. And it's a simple test to determine whether somebody has an overactive thyroid, and then we could treat that patient accordingly. In our next slide, you will also appreciate the fact that another entity was considered in our patient that I just presented to you, and that's called POTS syndrome, or postural orthostatic tachycardia syndrome. In this syndrome, what basically happens is somebody may have a normal blood pressure and heart rate while being in a sitting position, but when they stand up, their heart rate can go up to 30 to 50 beats per minute, and usually they have a fast heart rate above 100 beats per minute. And as a result, these patients have heart palpitations, they feel like they're having headaches, shortness of breath, they're feeling dizzy and lightheaded. After a thorough evaluation for this, our patient did not have POTS syndrome. And one thing to remember about POTS syndrome, you'll appreciate in the next slide, is the fact that we really don't know the clear etiology, but there are associations with past surgeries, there are associations with pregnancy, trauma, and even viral illnesses. So having ruled all of these other entities out, so to speak, with our patient, then we started to come to this question whether our patient could have a pseudo-pheochromocytoma, or sometimes called pseudo-pheo in short. So what is a pseudo-pheochromocytoma? Essentially, it's a patient that's having symptoms of a pheochromocytoma, but their imaging and biochemical studies are negative for a pheochromocytoma. And on the next slide, you'll appreciate the fact that on the right side of the panel, in a classic pheochromocytoma case, you have a tumor that's arising from the adrenal gland. And basically, this tumor releases the hormones called catecholamines. And those catecholamines basically increase the patient's blood pressure and heart rate. And the hope is that when this tumor is surgically removed, that these catecholamines now normalize, and therefore the rest of the patient's vital signs also begin to normalize. Now, in the circumstance of a pseudo-pheochromocytoma, the patient could be at risk of having some type of post-traumatic stress disorder. They may have had some type of traumatic event in their life where there's a reset, so to speak, in the central nervous system's activity. And as a result, the nervous system is overly active, basically stimulates other glands in the body, such as the adrenal gland. And as a result, the adrenal gland will make the necessary hormones to increase the patient's blood pressure and heart rate. And as a result, the person that is experiencing this could easily have the symptoms of what they would describe as having that pheochromocytoma coming back. On the next slide, I think it's important to acknowledge that the etiology of pseudopheochromocytoma is not well understood, although this entity has been heavily discussed in the last 25 years. We do realize that from research that there is an amplified cardiovascular response, and antihypertensive medications can help. But I would also like to point out the fact that this is a diagnosis of exclusion. So in our patient, certainly we did think about the possibility of pseudo-pheochromocytoma after pheochromocytoma or paraganglioma was ruled out. However, it was really important that we just didn't hang our hat on this alone. And in the next slide, you'll appreciate that there could be another differential diagnosis that could be playing a role here, and that's called a baroreceptor failure. And on the next slide, you'll see that when we were thinking about our patient, he was operated on in the neck. And as a result, he was at high risk for this baroreceptor failure. So in the next slide, you'll appreciate the fact that if somebody is in a lying position and they're all of a sudden standing up, their blood volume drops. And when their blood volume drops, there's a decrease in their heart's output. And there's also a decrease in their blood pressures, essentially. And this is sensed by these baroreceptors. And basically, there's a communication to the brainstem that tells the brainstem, look, there's a drop in blood pressures that we're sensing here. And basically, the brainstem activates the sympathetic nervous system in order for our blood pressures to be better regulated. So in our patient, what essentially happened was that there was a baroreceptor failure. We needed to collaborate with our cardiology colleagues to get the right type of antihypertensives on board so that the patient's not getting too much or too little, which was essentially causing his swings in his blood pressures. So other things to also think about in the differential diagnosis before you jump to the idea of pseudopheochromocytoma is, was the high blood pressure or the symptoms triggered by something? So For example, if somebody drank alcohol and the symptoms got triggered, that's another thing to think about. Another thing to think about, you'll appreciate on the next slide, is could somebody have a panic disorder? And in a panic disorder, this is usually can easily be elicited from talking to the patient and getting the history. But sometimes it takes a little bit of I would say this, it takes a little bit of time before somebody can really say, okay, this was a panic disorder that caused something versus another entity that really caused the panic disorder. And related to this is post-traumatic stress disorder, where there is indeed a traumatic event that is triggering the patient's hormones to go up, and therefore the patient is having the symptoms that is similar to pheochromocytoma. And pseudo-pheo would not match such a history. So having said that, I'd like to turn our attention to another case. This is a 37-year-old male who presented to the emergency room with hypertensive urgency. He had high blood pressures, a fast heartbeat. He had a history of pheochromocytoma surgically removed about a year ago. His biochemical workup from 6 months ago was normal. He had symptoms of pheochromocytoma, such as headaches, palpitations, occasional spikes in blood pressure. He had no known genetic mutations, and repeat biochemical evaluation showed normal metanephrines. And on the next slide, you'll appreciate his imaging, where on the right-hand panel, you could see he has some thickness of that left adrenal gland, but there's no tumor there. And on PET imaging on the left panel, there's really just physiologic uptake that we see. So this patient is biochemically normal, and by imaging, he has no tumors that anyone can identify. So basically, what we did was we ruled out many of the other endocrine causes, such as thyroid disease, carcinoid tumors. Our rheumatology colleagues ruled out a vasculitis. On further history, it was found that he was having more anxiety due to job-related issues, and he was worried about his next meal, and he was drinking more and more caffeinated beverages in order to stay up at night and finish his work. And I would say this: as soon as we were able to gather this history, and he was able to actually taper his caffeine, he's actually started to do well, and he's actually doing great right now. So when we're thinking about management, when somebody's having symptoms that are similar to pheochromocytoma, yet there's no biochemical evidence or imaging evidence, the management really depends on that underlying diagnosis. So if there's another underlying diagnosis that is in play here, it's important to at least think about that and consider that. And I think, and along with that comes the history of the patient in terms of identifying where to look, how we can pursue that workup to determine what else could be going on. And I'll say this: sometimes we're not able to find the exact etiology of what is happening. And at that point, we actually do fall into this idea that potentially they may have that pseudo-pheochromocytoma symptomatology. And therefore, we would actually treat these patients with different classes of antihypertensive medications, such as alpha blockers, beta blockers, or calcium channel blockers. On the next slide, you'll also appreciate the fact that sometimes we have to do a combination of these agents. And in specific cases, we've been able to identify patients that have had increased anxiety and depression. And when that was revealed and actually treated, these folks actually got much better. And it's almost like a day and night difference once something is found, let's say an underlying depression, which is basically causing more symptoms of anxiety, and addressing that actually does wonders. And the patients that we've seen like this, they're doing really good. So I think these are in specific cases. Not everybody necessarily has issues of depression, but I think it is important to at least think about, because if we're overlooking something like this, we are not necessarily doing our patients justice either. So on the next slide, I'd like to conclude by saying this. If the workup of recurrence is negative and somebody's having the symptoms of pheochromocytoma, for all of you out there that's experiencing this, these symptoms are not imaginary, and I can tell you they do exist. And so I'd like to reassure you about that. But also remember that if the metanephrines are negative and there's no tumor on imaging, it's less likely to be a pheo or paraganglioma, because of the fact that if these tumors are making hormones and they're continuously releasing hormones, we're able to measure those stable breakdown products really well. And therefore, the likelihood of saying that something is just hiding somewhere seems to be less. And also, other points I wanted to make are the fact that if there's no tumor found, another differential diagnosis should be considered. And when we are not able to find other differentials that actually fit what is going on with the patient, sometimes symptomatic treatment with antihypertensive medications can be helpful in selective patients, especially depending on their blood pressure levels. I will say this, these symptoms are very challenging, and it's important that you do not give up and you continue to follow up with your healthcare team. With that, I'd like to thank many of my colleagues across the country who I work with and appreciate, getting their feedback. And also, I appreciate many of my colleagues across the College of Medicine at the University of Florida from many different departments, because really this whole thing is a team approach. And as a team, are we able to make a difference in people's lives? And I especially want to acknowledge our patients and their families, especially for all the challenges that they face and everything that they go through. With that, I thank you so much for your attention, and I'm looking forward to addressing your questions.
Dr. Ghayee, thank you so much. What an absolutely fantastic set of slides. We appreciate your time so much. So we will go ahead and get started with the questions. The first question is something I'm actually going to answer, which is, will this be recorded? And if so, how can I get access? Yes, this webinar will be recorded. The recording will be available on the PheoPara website, as well as the YouTube channel within the next few days. We will also be providing a question and answer document that has everything transcribed. So you can always refer back to that. So the second question we have, Dr. Ghayee, is from a patient who says, many people I know that have had a highly secretive pheo for many years before it was found and removed, including myself, developed POTS, small fiber neuropathy, MCAS, and other dysautonomias after removal. A PPGL-versed doctor has told me that it's entirely possible that they have seen this in a cohort of pheo patients, sort of a subset that never really fully get better. Would you be able to comment on this?
Sure, and I would actually agree with that. There is that possibility in a subset of pheochromocytoma or paraganglioma patients. Unfortunately, I think there is not enough information or data, but I can say this, and this is the bright side of all of this, is that there are a lot of dedicated pheochromocytoma investigators who are interested in looking at such questions, and they're trying to actively answer them.
That's great. Thank you so much. This is a very good question. What effect can prolonged adrenaline exposure have on the body? For example, nerve pain or generalized pain that continues after pheoparasurgery.
Yeah, that's a good question. I think when somebody has high levels of norepinephrine or norepinephrine, which can cause changes in the cardiovascular system, when there are changes in the cardiovascular system, basically the person has high blood pressures, and high blood pressures can lead to all kinds of organ damages. So if we think about the ramifications, the end result to that, somebody is at risk, could be at risk for a stroke. They could be at risk for a heart attack. They could be at risk for having heart failure. And also other organs can be damaged, such as the kidneys, which as a result of this high blood pressure, which is driven by the norepinephrine levels, high levels of norepinephrine levels, with enough time can cause the right end organ damage in any patient that has these types of problems. So the answer is yes, but I would say this, that different patients may experience different types of end organ problems. So some may experience a stroke, or others might experience problems with their kidneys. So I think it really depends on the individual case, but yes, there is a lot of damage that can be caused from this.
Yes, thank you. It really is such a terrible disease, as I know personally, having suffered from strokes and a heart attack, and continue to sort of struggle. The next question is: overwhelming fatigue normal 11 months post-surgery for a left-sided adrenalectomy?
I think it depends on the case. So I think it's also important that if one is having overwhelming fatigue, even 11 months after surgery, that they talk with their endocrinologist to see if there are other hormones that need to be checked to determine the cause of their fatigue. And certainly sometimes we're able to find other things that could be related to the surgery that might explain that fatigue. So my advice is to go back to your endocrinologist, ask them to work them up for that fatigue associated with adrenalectomy. And I think it is important that that they get that continued close follow-up, because if the workup that they get post-adrenalectomy shows that there's no other adrenal hormone problems that exist and other issues related to post-surgery do not exist, then I think at that point it's back to the drawing board in terms of what's causing that fatigue. But there could be a chance that there could be something secondary going on, and it's worthwhile making that visit to that endocrinologist and letting them know.
Great, thank you so much. Next question I have here. Is there any one test that is superior to the other tests when it comes to detecting an otherwise undetectable pheochromocytoma that is causing problems?
That's a fantastic question. As a matter of fact, they're all fantastic questions. So in terms of the diagnosis of pheochromocytoma, we rely on several different tests, not just one test. So we like to use the blood test to look for biochemical evidence. And sometimes when we have a high enough clinical suspicion and one test is not, let's say it's coming back normal, yet we have a high clinical suspicion, we will definitely repeat the test. And we might also jump to another test, such as the 24-hour urine. They both are excellent tests. And then in terms of imaging, we would consider doing a CT or MRI depending on the individual circumstance or the individual case. For example, if the person is a child or of reproductive age, then we would definitely consider an MRI over a CT scan. But the tests that we utilize in order to diagnose a pheochromocytoma or paraganglioma are several different tests put together.
Mm-hmm. Great, thank you so much. This is an interesting question. Is it possible to have symptoms after a pheopera removal? Would it not be possible to have these symptoms prior to finding the original tumor? So interestingly, this is a similar case to what happened to me, where up until my heart attack, I had no symptoms. I felt totally fine. And then out of the blue, I had a heart attack and then strokes. But I had no symptoms prior, no high blood pressure, nothing. So this is a very interesting question for me to hear your answer on.
Yes. So I would say this, about 20% to 25% of patients that have a pheochromocytoma probably have not had any symptoms. They even had a normal blood pressure prior to their diagnosis. And that's the reason why, even in circumstances where, let's say, somebody was incidentally found to have an adrenal mass when they were being scanned for something else, we still rule out a pheochromocytoma even though they have no symptoms. So yes, that can exist and does exist. And now, what about the question of somebody being asymptomatic prior to surgery and then all of a sudden becoming symptomatic after surgery? And I think this can certainly happen. And the reason is this: it depends on what is going on with the patient post-surgery. So where was the surgery? Did the patient, for example, was in the neck region, or did the patient have some other things going on at the same time along with their pheochromocytoma that all of a sudden got, that's actually causing awareness and attention, whereas before it didn't prior to the surgery. So the answer to the question is yes, that can happen. And
Mm-hmm.
and is it possible that somebody can have no symptoms prior to surgery? And the answer is absolutely yes.
Great, thank you so much. I have another question here. Have you had any success treating symptoms of a para when not yet located on scans, but labs do indicate that there is a pheo? And it looks like this person was asking maybe sandostatin, or if so, what would you use to treat the symptoms?
Yeah. So if the patient has positive hormone levels, yet
Mm-hmm.
imaging is all negative, I do think about what could be going on with that patient. Am I getting some false positive results? Are they on some medication that could be causing the hormone levels to go up? So I do think about that as I'm thinking about such a case. And let's say I'm not able to find anything. And let's say the patient's history is not consistent with them taking any herbal medications or drinking caffeinated beverages or anything of this sort, or taking any type of decongesting agents that would cause their blood pressures to go up and also cause slightly elevated norepinephrine levels. So let's say all of that is negative, and I'm looking at some lab values that are a little bit elevated. Under that circumstance, and then if after I've really exhausted a thorough workup, that's when I might put them on either alpha or beta blockers or calcium channel blockers,
Mm-hmm.
depending on their medical history, to see if I
Mm-hmm.
could help them with their symptoms. Now, the question of sandostatin is a fantastic question. because we have learned that, these types of tumors, some of them can express high levels of the somatostatin receptor. So the question is this: what about giving a analog that might actually affect those receptors? And clinically, in my experience, as well as the experience of many other, I would say, endocrinologists or endocrine oncologists that have been really interested in this area, they've not really found much of an effect in terms of symptoms. And in
Hmm.
my own experience, I've not found any real effect in terms of symptoms either in my own patients.
That's great. Thank you so much for answering that question. This next question, also a very good question. What would you say in your clinical experience has been the leading cause of symptoms after the removal of a pheo, especially if biochemical testing is normal?
So the leading cause of symptoms post-surgery,
Hmm.
especially when biochemistry is all normal. So post-surgery, I've seen a lot of patients actually have lower blood pressures. They tend to get dizzy. And we're really careful not to add on their blood pressure medications post-surgery so they can avoid such side effects. I've seen fatigue as another common cause, but even with fatigue, I like to make sure that there's nothing else that we're missing, any of the other hormones that the adrenal gland needs to be making, to make sure that they're still making those hormones. So those are some of the more common things I do see and do think about. The other thing is this: post-surgery, we are very careful to make sure somebody's blood sugars are not running low, because high catecholamines can basically inhibit the release of insulin, and therefore these patients tend to have higher blood sugars when they have the tumor in some cases. And then
Hmm.
post-surgery, they can be at risk for having low blood sugars. And so that's the other thing that we look out for to make sure that's not the case.
Okay, great. And I have a question here from the live chat. And the question is, um, let's see here. Um, what hormones would you check if somebody was complaining of fatigue post pheo removal?
Yeah, I do think about cortisol as another hormone to check post-surgery if somebody's complaining of constant fatigue. That is one hormone I do absolutely think about. I think that becomes an important one because if if the patient is was affected by that surgery, and it seems like the cortisol that patient was making is just not good enough, is that a possibility? Because sometimes some of these tumors can co-secrete other hormones, and that's why I like to be aware of certain things. Usually we would know about this prior to surgery, but occasionally you want to be aware of such things in order to make sure that that is not happening. The other thing I like to make sure of their electrolytes. That's probably the more common thing that I like to make sure of that is normal. Other thing I like to think about is their blood count. Is their blood count normal? Because if there was some blood loss, that could also affect things. Other things I like to think about are iron levels. So are they anemic, where their iron levels are low and therefore their blood counts are low, and that puts them at higher risk for being more fatigued post-surgery.
Hmm. Great, thank you so much. And then one other interesting question. So, say somebody has had an adrenalectomy, um, or they have adrenal insufficiency for some reason. Would that alter the testing that you would do for a pheochromocytoma? Say, would that, if a patient only has one adrenal gland, would their metanephrine level be different than somebody who had two adrenal glands?
Yeah, so if somebody has one adrenal gland, theoretically, so after that first adrenal is removed and they have one remaining, theoretically, um, the other adrenal gland would kick in and basically make all the necessary hormones the patient needs in order to function well. Now, if somebody has had that adrenalectomy, and the question is this: do we need to make sure that the metanephrines are okay right afterwards? Usually, that's not recommended right afterwards. I think what we are most worried about is not how high the metanephrines are. I mean, rather how low the metanephrines are. We're usually worried about how high they are post-surgery, and so I think that becomes really important when we are dealing with a patient that's had that adrenalectomy and you're worried about adrenal insufficiency. You're really worried more about cortisol than you are with metanephrines at that point, immediately post surgery. But several weeks post surgery, and you're seeing the patient in clinic, that's when I think it would be a good idea to check metanephrines just to make sure that everything is working well for that patient.
Okay, great. And I think we have time for one last question. Is adrenal medullary hyperplasia ever considered as a diagnosis?
Yeah, so that's a great question, and I think we do think about whether that is consistent with something that the patient could be having in terms of symptoms. But I think what is also important that goes along with this is if somebody's had a pheochromocytoma before or has a pathogenic variant in terms of being predisposed of having a pheochromocytoma, that becomes an important thing to think about in terms of whether the person could be at risk of developing a tumor. So I think when I am evaluating patients, I definitely consider that, especially when I'm looking at a case that has a pathogenic variant, and certainly that would be at risk for developing a pheochromocytoma. But oftentimes when we look at somebody's imaging and we see that somebody has a little bit of a hyperplastic adrenal gland, that does not necessarily mean that they have a tumor there that's making high levels of catecholamines. So I think there's a little bit of a difference in terms of thinking about this. So that's why I would say this, that if I know somebody has a specific hyperplasia on imaging, and I also know that their biochemistry is negative and they don't have any tumors anywhere, I would not act on that in terms of saying, okay, we need to call the surgery team and get this taken care of. Instead, I would just monitor the patient and make sure that there isn't anything else that we need to work with here.
All right, that's great. Thank you so much. Dr. Ghayee, I cannot express how thankful we are for your time and your dedication to our patient community.
Well, I'm really thankful to be here, and I hope I could help anybody that I can, and I certainly hope the folks that have been listening are able to at least get some information out of this. Thank you
That's
so much.
wonderful. Thank you. Thank you again. And as a note, this webinar will be available in a few days on YouTube and on the website. We will transcribe the question and answer portion. That will be available as well. You can sign up for our e-news and follow us on social media. If this information has been useful to you and you are interested in donating, you can do so at pheopara.org/donate. A special thanks again to Lantheus Progenics for making this webinar series possible through an educational grant. And again, thank you to everybody who attended today. Hope everyone has an amazing day. Bye-bye.